Ann Ciriello. I'm one of the burn and trauma nurse practitioners, and I'm going to be talking about pediatric burn management today. So before I get started, who's taking care of burn patients? With a show of hands. Okay. And what kind of locations are most people in? Emergency department, OR, emergency, a lot of emergency. Okay. All right. So that just gives me a little bit of background. I'm going to talk about a few different things when it comes to burn injuries, the mechanism, general kind of burns and what we see, the burn assessment, how to evaluate the different depths of burn injuries, the management of a patient who has a burn injury, and then what our treatment options are. I'm starting with this resource because I could talk all day about burn injuries and really break it down into more specifics, but I am trying to give you just a brief overview of a lot of different aspects of burn care here at Children's National, but we have some really great resources on our Trauma and Burn YouTube site. This After the Burn is actually one that's targeted towards families, but it's really helpful for providers as well. So if you go to that link or you use that QR code, we have some really great videos there. And then we also, if you haven't heard of our burn cast and trauma cast, which you probably had, Cindy has put these together. I really like our burn cast. One of my favorite ones is actually the last one that we did, which was episode 16, which talks a lot about why we can't make up our minds when it comes to burn treatment. And we come in with a lot of different options. We come in with topicals, we come in with bandages that leave on for play, and we make decisions based on so many different factors, and I really liked that discussion. So if you're interested, check those out. Those are also on the Trauma and Burn Education YouTube site, and that is eligible for CNEs. So just by the numbers, we have over 250,000 pediatric burns in the U.S. annually. Of that, we see about 2,200 burn visits in here at Children's National. These are slightly outdated. This is fiscal year 21, but we see about 1,600 clinic visits, outpatient visits. We have about 80 to 90 patients who are admitted for burn injuries, and then the emergency department sees somewhere around 500 to 600 patients who are seen in the emergency department. We also have a telemedicine program, so we see patients virtually as well. This is just a list of patients who are seen in a non-burn center who should be referred to a burn center. So if a patient has a large enough burn, a full thickness or third degree burn, if there are certain areas of burn, if you're worried about NAT, I know you heard from Dr. Artis earlier, or if there's any sort of social concerns, or we have inhalation, chemical, or electrical injuries, those are ones that we want to make sure that we see here and are referred to us. Burn centers in the area, Hopkins is one, we're the only burn center in the DC metro area, and then I think the next one south is probably Richmond. So I'm just going to go through kind of the common mechanisms of burn injury. Scald and contact are our top two. The other mechanisms of burn injury, which I will discuss as well, are flame, mechanical, or friction injuries, and chemical or electrical injuries. I like to go over this a little bit because safe bath water is 100 degrees Fahrenheit. You can have a serious burn injury at 155 degrees Fahrenheit in 1 second, and at 140 degrees, it can take 5 seconds. Generally, it's recommended that a hot water heater is set at 120 degrees Fahrenheit, which, if you really like scalding showers, is not that hot. But if you have kids in the home or you're in an apartment building, we many times have had kids bathing where the hot water gets knocked the wrong way or the cold the wrong way, and the kid is burned just from being in a bath. To put this into perspective, hot oil fries at 500 degrees Fahrenheit. So if you can burn with a serious injury at 1 second at 155, to think that at 500 degrees, we have really deep burns that come from hot oil. So the mechanism does make a difference. If you're baking, up to 400. Stovetop cooking is generally 300. A crock pot is about 200. Boiling water starts at 170. So if you're thinking coffee, tea, etc., we have some burns from that as well. And then I mentioned this as the safe bath water temperature. Scald burns are our most common burn injury that we see. Generally, toddlers. So there's two main mechanisms of distribution that we see in the toddlers because they're small, they reach up to counters, they're curious, they pull hot water, tea, coffee, soup. I mean, we sometimes see things like oatmeal, which I could argue is maybe scald and contact, but they pull hot liquids down onto themselves. So oftentimes this means that because it's coming from above, they will have injury to their face, their chest, shoulders, arms, backs. That's a very typical distribution. You'll see splashes to other areas. And then we have our older population, our teens, our school-age children, who often, we see so many hot soup. It's called hot soup, but it can be ramen, it can be cup noodles, whatever the variety is. And oftentimes this happens in the lap and the groin because they spill it as they're eating, although occasionally they do that taking out of the microwave as well. And then another injury that we see pretty frequently is when patients are dipping their braids. When you're finishing with the braids, I believe it's to curl them, you dip them into boiling or hot water. And we've had either the braids hit the back, spilling and scalding the back, or spilling the container that you're dipping the braids into. So we do have a number of those injuries as well, and that's a distribution that usually is on the back of the patient, occasionally on the shoulders. Contact burns, I mean, these are just our curious toddlers. They want to touch and put their hands on everything. They have pretty slow reflexes. Multiple times I've had a parent come in and say they touched the fireplace and I stood there and they didn't pull back. Like, it's not as quick as we do. If we touch a hot pan, we usually pull back pretty quickly. Our toddler population doesn't do that. They can have, if you have contact to the burn or to the thermal source, you're more likely to have a deeper injury, whereas hot water will kind of splash off and is more likely to not have a sustained contact. If you are touching something for a prolonged period of time, and if we're talking about a fireplace that gets to 500 to 1200 degrees, that's milliseconds that takes to have a burn injury. We also I've had a patient who tripped and fell into their mother's hair straightener, so had like a clamped on hot pad basically on either side of the arm. So we get some pretty deep iron burns. In the summer, we get a lot of fire pits, and so these kids can have some pretty deep burns from contact injury. Flame burns tend to be our older population. Flame burns are the type of burn that is most often associated with death, but this is when it's related to the smoke inhalation. And smoke inhalation occurs in an enclosed space. So if you have a flame injury from a bonfire outside and you have some singed nose hairs, it's something we're always looking for. That's less likely to have a long-term impact or significant impact as having a truly enclosed space. So we're talking about house fires and things like that. Flame burns are, fire is much hotter than a boiling water, and so it gets to be a much deeper burn injury. Also, sometimes if an article of clothing ignites, it takes some time to actually put the burn out, right? So that can stay at a higher temperature and cause a deeper injury. We often see full thickness flame burns. Not something that you would necessarily consider or think of as a burn, but we see a lot of friction injuries. So this is like a road rash. It's basically the worst form of a skinned knee you've ever had. You know, you fall and you skin your knee is one thing, but if you get dragged by a car, that friction keeps going as you're dragged along, or if you're having some sort of road rash injury. This is managed by the burn team. Anytime someone has a friction injury, it's often something where we want to make sure that we're ruling out any osseous injuries, so we want to have an orthopedic workup as needed. And then in addition to road rash, I'd say the most common friction injury that we see is treadmill injuries. So treadmill injuries can be really serious. The problem is that if kids, especially if either someone else is running on the treadmill or the kid is playing on the treadmill doesn't stop necessarily when you fall. So the treadmill keeps going, and if your hand, it's often hands, and I actually have a picture of a treadmill injury here. If the hand gets stuck in a treadmill and the treadmill doesn't turn off, it keeps going and you have further injury. Recently a treadmill was recalled because it was a little bit higher up off the ground and kids were actually getting like stuck under the treadmill. I think there may have even been a death related to that, but we see some pretty serious treadmill injuries, and oftentimes, especially if they're on the hands, we really want to make sure that we're getting function back. Chemical burns we don't see as frequently in kids, but they are a thing. The most important thing I say with this is that we really want to flush out whatever the chemical is that's involved in this injury and get poison control involved, because there are many different things that could cause this. We don't use neutralizing agents, but we do really refer to poison control about what we need to do if there's an exposure to a chemical, and then we will proceed with working on healing the burn. Electrical burns, this is, I'm not expecting anybody to read this, and I'm certainly not going to read this to you, but this is our stable electrical injury. We also have a pathway. We also have an unstable electrical injury pathway, so we do have this in place. The long story short of all of these colored boxes is that a healthy child who's exposed to normal household currents, which is usually less than about 240, and has some sort of cutaneous injury, generally, if there are no other symptoms like loss of consciousness or cardiac arrest or anything else that kind of happens with this, it's a little like shock and a small cutaneous injury. Generally, these patients don't need an in-depth workup, don't need to be admitted to the hospital. If you truly have a severe electrical injury with or without cardiac arrest, we're looking more so at rhabdomyopathy, and we're looking at our urine myoglobin and resuscitating patients, and that's a whole other story that we're not going to get into today. But just knowing that generally, like a little small kind of household level electrical injury with a small local injury, sometimes these patients have such small local injuries that they don't have to follow up in clinic. But again, that's a topic for another day. Oh, this is the kid who obviously put their mouth on a cord or something along those lines. That is a deep injury, but unfortunately, unless you have to get like a surgical intervention from this, there's not much you can do on the lips for a bandage, so you would kind of support this, and the lips actually heal relatively well. All right, so this is immediate treatment outside of the clinical setting. So like you're at home, somebody gets burned, you're trying to educate a family about what to do when they get burned. The number one thing you want to do for any type of burn injury is to stop the burn. So like clothes on, take them off. If there's a hot source, remove it. You want to try and cool the burn if you can. So we like cool water, but we don't want ice. We don't want cold water or freezing, because we don't want to vasoconstrict, right? So we don't want to shut off the blood flow to the burn, but we want to stop whatever the contact, the scald. If there's hot oatmeal or something, hot glue, you want to get it off of there so the burn can stop. Not to put toothpaste, eggs, honey. I've seen many different things come in on burn injuries. These are the best thing to do if there's a burn that cannot be managed at home, is to bring them for care with like a clean dressing, a clean sheet, or some sort of clean cloth. This, toothpaste, egg, and honey all just solidify and then have to be further debrided off, which is more pain for the child. So we don't want anything on that burn. If it's going to be treated by us, we just would rather kind of get the first debridement done. Obviously, that depends on if you have a burn that's the size of a quarter versus a burn that's a large percent of somebody's body. But generally, stop the burn. Don't put any food products or toothpaste on it, and get to a treatment center. So now I'm just going to talk about the assessment of a burn injury, a little bit about the depth of burn injury. This, hopefully you guys can see this well enough. Do I have a point? Is this a pointer? Oh, okay, perfect. Okay, let me know if you can't hear me, okay? So this is the layers of the skin. You have the epidermis, which is the outermost layer of your skin, and then this whole area is the dermal layer. This is the dermis, and then underneath is the subcutaneous or fatty tissue, and then here's the muscle underneath the subcutaneous tissue. I'm going to go through each of the three main types of burn injuries, but I like to look at this diagram because it explains them before I show the burns themselves. So we have, if you just have the involvement of the epidermis, you don't have any blistering, this is kind of like a sunburn, this is considered a first degree, or that's layman's term. We have burns, we label them superficial, partial thickness, and full thickness. So it's superficial, partial, and full thickness. And superficial means it's superficial. Then there's partial thickness, which goes through the dermis. Superficial partial thickness is in the more superficial part. I mean, it seems kind of obvious. I'm sorry, I'm like repeating what it's the actual name is the description, but it's more superficial into the dermis, and then there's deep partial thickness. And we consider partial thickness burns are second-degree burns in layman's terms. When you have a full thickness burn, it goes all the way through the dermis and into the subcutaneous tissue, and that is a third-degree injury. And so this kind of diagram here shows the burn is just in the epidermis. It's a little bit into the dermis depending on the two types of second-degree or partial thickness, and then a full thickness which goes all the way through. Some people talk of a fourth degree, which makes it down to the muscle. We generally stick to superficial, partial, and full thickness burns. So if you're looking at a superficial burn, this is a sunburn. This is a red, it's blanching, it's painful, it hasn't blistered. If it hasn't blistered, we don't calculate it in the TBSA or the total body surface area. This generally heals in less than a week. These patients don't have to follow up with us in burn clinic because it is not an open wound. It is still a burn injury, but it's not calculated in our total body surface area. This will not scar. It may be painful. It's treated with topical ointments, Aquaphor, aloe, etc. But this is our most shallow or first-degree burn. Then I'm going to talk about, this is our partial thickness burn. So that's a second-degree burn injury, and this is superficial partial thickness. So the more shallow of the second-degree burn. If you can see on here, actually this entire part of this patient's face is burned, so it's very pink, it's moist. If this patient had darker skin, you would see a lot more clear lines of demarcation of where the burn itself is. There's pink and moist here, so superficial partial thickness burns are moist, they're pink, they're pretty painful when the blisters have come off because once it's exposed to air, it is an open wound. This generally heals in a couple weeks, sometimes less than a week. On this patient here, I see two spots that are a little bit more red or hyperemic, and they're probably on the deeper side of partial thickness or a little bit deeper than other areas. Burn injuries are very heterogeneous. It's hard sometimes with treatment if you have a spot of third degree with some shallow second degree and some deep second degree to kind of choose your treatment, but it is that you will see that I may call this superficial partial thickness, and this may end up being more deep partial thickness. Rarely does this leave a scar, but we still manage these patients with bandage changes and wound care. When you're looking to determine if you have a deep partial thickness burn, we look for things like this is pale and yellow. It might not have blanching. There's a lot of capillary bursts. So when I see this hyperemia, these red polka dots, this redness along with a yellow or pale or white interior, that's when I know that I have a deeper partial thickness burn or a deep second degree burn. This can have pain, but some areas, if they're deep enough, might not be painful to the touch. This generally takes more than 2 to 3 weeks for scarring or for healing, and is more at risk for having scars. This, I just saw a little thumbs up go by. I don't think I put a thumbs up in there. Well, thank you for the interrupt me if you need anything, but if I need to do anything with your emojis, Cindy, let me know. All right, so this is the full thickness burn. This is, we call this a scar. It's white, it's brown, it's dry. Dry is not good when you see a burn injury. This is a burn that probably is full thickness in the middle here and maybe has some deep partial thickness more so around it. This burn has gone all the way through the dermis and is down to the subcutaneous fat. In a burn that is about the size of a palm, and there's some central small areas of full thickness injury, you may be able to get that to heal. If the burn goes all the way through the dermis and there's no healthy skin cells, the burn then has to heal from the outside, from wherever you have dermal layers in. So if it's a small area of full thickness injury, you may be able to get it here to heal primarily with wound care and bandage changes and things like that. But if you have a larger burn, that is more so the size of this is an entire torso and arm, this is not going to be able to heal on its own. This needs a skin graft. This does not have enough dermal layers, enough dermis involved or healthy skin cells to be able to heal on its own. Full thickness burns will scar. There is nothing we can do about it. We try and make the best scar that we can get, but full thickness burns are going to scar. So when we're talking about a burn assessment, we also want to take into consideration where the injury is, if the face is involved, is the kid going to eat, if the hand is involved. You may have seen, I don't know if Dr. Artis talked about one of these, but you may have seen something along these lines. This burn concerns me. This is a submersion burn. I can see that all fingers are involved and not just on the front. If they touch something hot, it would just be the palm. If it splashed, you'd see some splash marks on some parts of it. There is a line of demarcation on this burn. I'm worried that accidents happen and splashes happen, right? So if this kid had accidentally put their hand in something, you probably would see some splashes instead of a very strict line. Now, that's not always true, but this is a red flag for non-accidental trauma. And so we want to be cautious of things like that. We're also very wary of when burns cross joints because we want to maintain function. And then here with the neck involvement, this patient is going to have a hard time probably between the facial involvement and the neck involvement. This is a pre-debridement photo and this is the post-debridement photo. Probably a hard time eating. When we're calculating the total body surface area, we shorthand it as TBSA. You take the patient's palm and hand, fingers and palm, not my own, the patient's, right? That in the little kid, their hand could probably fit on my hand twice, right? If you take the patient's, it's called the rule of palm. 1% is their whole fingers and palm. I think this is the easiest way to do a quick, look at a patient and tell without using an app. I'll show you those in a second. And I have been known to take the patient's hand, especially if it's like chest or something, and pick up their hand and put it next to their burn, or even take a picture of their burn with their hand next to it to kind of gauge, because you'd be surprised about what the size is of a burn. Burns look very overwhelming, and we'll have patients come in where someone says it's 20% total body surface area, it's the whole chest, and then when you really calculate it down, it's 6%. So and the importance is we determine our treatment, we determine our triage, we determine our fluid resuscitation based off of the TBSA. So it is really important that we get an accurate total body surface area. This app created by Cindy is the Easy TBSA. This is the most accurate app that I've ever used out here in terms of calculating the total body surface area. You put in the patient's age and weight, so you can do this for any age child, and then you color in very specifically on different parts of the body where the burn is. We're looking at post-debridement wounds, not including the first degree or superficial injuries. There's also another one called NSW trauma. It's not as specific, but it has like a general big picture. But I like this one. So those apps are really helpful. I'll often estimate what I think they are on my rule of thumbs or by looking at it, and then I'll double check with the app, and then I'll kind of meet in the middle depending on what it looks like. When we're talking about TBSA, anytime a patient has a face burn and it stops at the hairline, I'm a little curious, because it's not often that you spill a cup of water and you only spill it from here down, right? Or you knock something into yourself and you don't get, it stops at the hair just because the hair there. So very often we do have patients who have scalp involvement of their burns, and I have clippers in my office because I gave 2 haircuts last week, I think. We have to shave the head depending on the thickness of the hair, the extension of the injury, and being able to treat the injury. So if you look at this patient before he had a haircut and after, oh, I think it died. Well, if you look at the patient before the haircut and then after the injury, on that side, you've got an additional 3% potentially total body surface area that is included in now his calculation. And we also have a larger burn that is going to be more impactful on the patient's hemodynamics and his healing process, and we have more wound care to take care of. So this is really important to keep in mind, is that if you have a face burn that extends to the hairline, to really check the scalp, because sometimes you think it just goes in a little bit, and then when you start really looking at it, it's half the scalp. This is my hot tip to get the best information you can about a burn patient if you're looking at a chart where one of our burn team has been involved. This is how we document like a quick one-liner with every bit of pertinent information about a burn patient. I want to know when it happened. On the day of, I want to know the time that it happened, if Parkland's involved, because, and I'll show you about that in a second. But if it's 4 days later, I just want to know that we're 4 days out from a burn, because a burn that hasn't healed yet in 4 days, I don't have a problem with. But a burn that's 27 days out and hasn't healed yet, that's a different story. So I want to know what burn day, month, year, weeks, how far we are out from the burn. So we'll generally say something like a 14-month-old who's post-burn day 3 from whatever total body surface area. What was our partial thickness, full thickness, total body surface area of burn? What depth of thickness was it? So I want the size, I want the depth, and then I want the location. I don't need like right pinky finger, upper part of right arm. I just need like chest, neck, head, kind of general overview of where this is and what it came from. So is it hot water? Is it oil? Because water, as we discussed, is 170 degrees and oil might be 500. That's a different burn injury. So this is how we write our one-liner. If you've ever seen a note that our nurse practitioners have gotten their hands on, this is how it's going to be written, and you can get a lot of information by going to the part of the note where it's a clinic note, it's an H&P or whatever it might be. A lot of information from that part of the note about what's going on with that patient today. All right, so I'm going to discuss some of the burn management. These are criteria for a burn consult. I'm not going to read them all to you. Basically, this is if a patient comes into the emergency department and they have a full thickness burn, they have a burn in certain areas that are high risk, they have a treadmill, flame, or oil burn, we want to know about them. Or if there's like NAT or some other concern, we want the burn team to see them. The emergency department does an amazing job taking care of the patients who don't meet these criteria, who come in with a burn, need it cleaned, debrided, a bandage placed, and then they can follow up in clinic. But when a burn surgery needs to get involved, it's for these reasons. We generally determine where a patient goes to, depending on the size of the burn. There are other things that we take into consideration, but if it's less than about 5%, you can go home from the emergency department on most instances. If it's 5 to 9%, we're talking about an admission, depends on the age. If it's 10%, you're coming to surgical care. If it's 15 or more, you're going to the PICU for Parkland. If it's a 25 or more, we're trauma activation. And if it's 40 or more, this is a trauma stat attending activation. When we talk about fluid resuscitation from the minute the patient gets here, for anybody less than 15% total body surface area, when they come to the emergency department, we just do maintenance fluids, unless it's someone who has a small burn that doesn't need fluids and is going home. And then we try and get enteral feeds involved as soon as we can. If they're greater than 15%, the patient in the emergency department gets 1.5 times maintenance. We do the Parkland in the ICU, and our goal is to get the patient up to the ICU within an hour. So this talks a little bit about what the duties are of the emergency department and the PICU when a significant burn comes in, which is 15% total body surface area or greater. In the emergency department, we want a quick estimate of the TBSA. We haven't done a debridement. We may uncover more, but we want to make sure we get kind of a general idea of how large this burn is. We want to make sure we get how much accurate information, as much as we can, about how much fluids this patient has received, either in an outside hospital, in transport, or in our own emergency department. This patient will get started on the 1.5 times maintenance. We don't bolus, we start at LR, and then cover it with a clean sheet. If a patient is going to the PICU, we do the burn debridement and dressing in the PICU, under PICU sedation if needed. In the PICU, we get an accurate weight. Once we've done the debridement and we've exposed all the burn wounds, then we assess what a true TBSA is. That may change. Burns are very dynamic, so we may think our TBSA is 16%, and then the next day we come back, we do a bandage change, and we debride off another 2 or 3%, and we realize that we actually are up to 18 or 19. Additionally, the fluid resuscitation worksheet is started. A Foley catheter is inserted in the PICU, and we start NG feeds as soon as we possibly can. Parkland formula overall is 4 mLs per kilo multiplied by your total body surface area. That amount of fluid we want to resuscitate a burn injury with in the first 24 hours. Generally, we want half of that in the first 8 hours and the second half of that in the next 9 to 24 hours. If a patient has come in and we're at hour 5 and they've already received a quarter of their Parkland, we have a quarter left to give in the next 3 hours to complete our first 8 hours. This is generally the idea of Parkland, but we don't just set a rate and forget about it for the hours for every hour until the 24 hours. If a patient is less than 30 kilos, we do give them D5 LR maintenance, but the way that this happens is we go by urine output. So we start by calculating Parkland, and then we do an hourly urine output with the Foley catheter, and if the urine output is less than either 1 or 0.5, depending on their weight, we go up or down on the fluid. This is done in the ICU. This is the fluid resuscitation worksheet. You plug in all the numbers. It takes you step by step on how to do it. The PICU nurses are very great at getting this done. Your goal is to resuscitate the patient without having so much capillary leak that they become fluid overloaded and end up having compartment syndrome or having too tight of extracellular space. So it's very important that we don't over-resuscitate patients. They also are in a hypermetabolic state, so these patients will be tachycardic, and it's hard not to give a tachycardic patient fluid. So we go by urine output, we pay attention to the heart rate, we support the heart rate if needed, but we try not to only go by heart rate with giving multiple boluses, because then we end up in a situation where we're fluid overloaded and it is worse for wound healing. Nutrition is vital in burn injuries. Related to that hypermetabolic state I talked about, burn patients have a higher protein and calorie requirement than baseline, especially with bigger burns. It's important in wound healing. We get nutrition consult on any inpatient burn patient. If patients are going home with a burn, we recommend that their parents learn about what a high protein and high calorie diet is. There's a big role for nursing in this and family education. Instead of juice, can we try Pedialyte or Ensure? Can we try half Pedialyte or a half Ensure Clear and half juice? Can we use half milk, half Pediasure? What can we do that the child will like? We know these kids don't like to drink plain Pedialyte and milk all the time. So now's not the time to push vegetables if you can get calories in. It really is about nutrition. We have, we'll supplement with things like zinc, copper, selenium, if needed. So nutrition is involved in any of our large burn injuries to make sure anything greater than about 10% they're involved in potentially drawing labs and supplementing with vitamins. Any inpatient burn gets a multivitamin. That's a pretty low thing, easy thing to do. But we do more than that if we need to. Every inpatient burn gets a calorie count and a high protein and calorie diet. So this is a really important for us to get. If a patient is in the emergency department for longer than that hour or they're waiting for a floor bed, I love to see, even if it's just a void count, like they had a diaper, they peed. I don't need to know strict eyes and nose. When they get to the floor, we'll definitely do strict eyes and nose, but if we're able to know generally if this patient is making urine, it is helpful. If you haven't seen a nasal bridle before, I just wanted to highlight it briefly in case you see one on one of our burn patients. Generally, when we place these, they're placed by our nurse practitioners in the operating room because it is a little bit tricky. If you go to the bridle site, they play a video that says, you know, insert over the septum, basically, which is a little bit harder to do in kids if anyone's ever tried this. But what it is I'm going to try and use the mouse, is you insert a magnet and stylet, a magnet on this side and then a stylet with a string through it on this side, and you attach them on the back of the nasal septum, and then when they click, you pull the string through. So this is actually tied behind the nasal septum, and then it's a clamp that can be independent of the NG tube. So the NG doesn't have to be in the bridle for it to work. It secures the bridle in place. We use these for patients who have their entire face burned because you can't tape an NG tube to their face. We do have a backup plan. What we use for patients who have this is called a Montgomery strap, where we actually tie a string around the back of their head, secure it to their head bandage, and tie it to their NG tube. But that's a whole other story. But if you ever see an NG bridle, we're happy to help you with it. There's a little pick that you have to use to open it. But my biggest message is you don't have to take the bridle out if you're removing or moving the NG tube. So the bridle can stay in, and we can take it out when we're sure we're finished with feeds. It's basically don't cut the strings unless you're sure you're not going to need it again because it's hard to place, and we don't want to take them out until we're ready for them to come out. I always say when it comes to burn injury, like, we'll find a way to get the burn healed. Function is number one. Like, function is first. Healing the wound is important. We will get to that. Reducing scarring, cosmesis is important as well, but like, function is important. Physical and occupational therapy is very involved with our burn patients. They see almost every inpatient burn, and they come to our clinic and staff in our clinic when needed. So I'm gonna be a little hands-on because I'm talking a lot. So take your hands, right, and then count how many joints you have just on your hand alone. So like, you have this finger bends, but then it bends here and it bends here. So it bends at what's called your MCP, and then your interphalanges, you have a proximal and a distal. So you have 3 joints on this finger from here to here. You have 3 on each of these. Your thumb only has 1 bend, so it's got 2. But right there, there are so many joints moving your hands and your fingers. Additionally, another thing you can look at is we all walk around a little bit relaxed with our hands. Like, nobody's walking around flexed. If you touch your palm and have a burn on your palm, and it heals kind of like this, if you take your hand and you kind of relax it a little bit, look at your palmar crease. It starts to almost touch itself. So if your burn heals or is deep and has a hypertrophic or tight scar, what a tight scar does, it is actually ends up pulling on the skin around it. So it could pull your skin tight. Or that treadmill I showed earlier, if we don't get occupational therapy involved early in that, like from the beginning, that, if it heals, could heal tight and like a bent finger. So we really want, especially on here, two other very high-risk areas. If we have a full thickness burn in the axilla, your axilla you can end up not being able to raise your arm. So our occupational therapists will put patients in airplane splints. So you'll see them walking around in a splint that goes under their arm. Sometimes they'll have them all the way up. Patients with burns on their neck, if they have a really deep burn on their neck, they'll get to the point where the skin has tightened from a hypertrophic scar and they can't actually raise their neck up. So you may see occupational therapy say no pillows. They're not trying to be cruel. They don't want the patient to be flexed because they don't want the skin to heal this way. They want them to be able to maintain their range of motion. Occupational and physical therapy are so crucial in our function and so important. It may be splinting, it may be stretches. A lot of times we just have patients and families do stretches of the area. It may be positioning, and they're integral to our team. We also have a social worker on our burn and trauma service. In the emergency department, anybody who's less than 2 years old gets a social work consult. It's generally by the ED social workers, but all inpatient burns and anybody who has concern for the mechanism of injury has social work involvement. All right, so I'm going to go through burn treatment. So if you're looking at this burn, and it's a little bit of a giveaway because it says burn debridement, so I'm going to say we're going to debride this burn. But I see yellow. I see like kind of some red in the middle. I don't see a lot of pink. It might not show up as well up here, but you could be concerned this is a partial thickness or full thickness injury. But you get some pain meds. You get the team around, you debride this burn, and it's pink, it's blanching, it's healthy, it's something that's going to heal without any sort of surgical intervention. This is what the importance of burn healing is, so that we can evaluate the injury, or burn debridement, is so we can evaluate the injury and so that we can get the treatment onto the burn. If you imagine putting a Band-Aid on top of the pre-debridement photo there, you're not getting much through that thick layer of gunk and wound juice. Like you're not going to penetrate that. On the right side, you can get that burn to heal pretty well and pretty quick. So I'm just going to talk about the general burn dressings that we use. We use long-acting that can stay in place for up to a week. We use daily, and then we have skin grafts. We take into consideration, this is a skin graft. A skin graft is when you take a part of a patient's healthy skin from generally their thigh, you mesh it, and then you put it over where you've excised the full thickness injury. This is for full thickness injuries. and generally is done is always done in the operating room. A skin graft is going to scar. A full thickness burn is going to scar. There are many reasons why we choose to do a skin graft. I talked a little bit earlier about how if it's small enough, you can let it heal even if it's going to scar that way, but a larger burn that's full thickness will need a skin graft. We use Methylex AG very frequently. You'll see this in the emergency department. It's a silver impregnated foam that can stay on for about 5 to 7 days. You'll see drainage come through it. Generally, we change the first dressing change at about 3 to 5 days. If there is yellow or brown drainage on it, that's not a need to replace the dressing. It's not infection. It's not pus. Families may think so. This is a foam bandage to absorb the fluid. And so this is actually a great treatment that we can leave in place and not expose the wound and cause pain for the kid. Our team, the burn team, will use an Acticoat Flex, which is just a stronger, long-acting bandage. It's used with Mepitel. So if you see this on a patient, don't be surprised by it. It's similar to Methylex AG. It's a little bit deeper penetrating. It allows for drainage to come through. This is put on by our burn team. For daily dressings, many people have heard of Xeroform. This is an antibiotic impregnated petroleum gauze. It has bismuth in it, which is very similar to bathophysiology. We use these on any areas where we need to change the bandage once a day, or more. On the face, groins, ears, chin, etc. If it's dry or stuck and the family is like, we can't change it, it's stuck, or you're managing trying to do a daily Xeroform dressing change and it's stuck, you can soak it. You can put Aquaphor on top of it to try and get it to come off. If you're applying Xeroform and you want to try and prevent it from sticking, there's 2 things that I sometimes do. One is put Aquaphor on it and slather the Aquaphor on the Xeroform before I apply it to the burn injury. And sometimes I add a Telfa or non-stick gauze on top of it to try and keep the moisture in so it doesn't stick to the burn and makes removal easier. 2 of our ointments that are for full thickness injuries generally, occasionally very deep partial thickness injuries, or we use them on mechanical or dirty wounds, so those treadmill burns. We'll use them on road rash. It's like gravel in there. You really want to get it cleaned up. We will use Silvadene and sulfamylon. This is a daily dressing change. It can be very sensitive. We have to think about pain control. This goes on the most beautiful pearly white and comes off yellow and brown and foul, and it looks like pus, and it's not infection. And I tell all families this because it's very important that they know that this is not that it's all of a sudden infected. This is the ointment itself. Santal or collagenase is one that we've been using a lot recently, although there is a shortage, maybe because we're using it so much. It's an enzymatic debrider. It works a little bit like Pac-Man. It's very gentle. We use it on spaces. We use it on more of like a deep partial thickness burn. So it doesn't have antimicrobial coverage, so we apply it with a different, either a Xeroform or a Methylex AG. So if we're like, apply Santal with Xeroform, don't think we're crazy. There is a method behind the madness here. Bathophysiology, most people know, we use this pretty frequently on burns. Facial cares can be very overwhelming. A lot of times our families have to do this. The swelling, especially if the central face is involved, gets worse before it gets better. It really peaks around like 2 to 3 days and then starts to get better. We soak with Bosch, which is hypochlorous acid, or soap and water, and really try and get any dried skin off of there, any old debris. The central face requires a frequent application of Aquaphor. The most important thing about facial burns is to clean off the old Aquaphor, because kids will come in with like 5 days of Aquaphor pasted on their face with wound, drainage as well, and it's really hard to get it off, and it kind of inhibits our healing. It's okay if they bleed. It's very likely that face burns will bleed. They have a lot. They heal very well. They bleed a lot and they heal very well. They're very overwhelming, but usually they're the first part of the body to heal. This is a partial thickness burn, and this is it epithelialized. When this is a healed burn, it's very remarkable, especially with patients who have darker skin, that the healed burn, we tell them it's healed, and they're like, well, that's not healed. That's not right. That doesn't look like a healed burn. The melanin in the skin gets burned off when the skin does. Melanin takes months to come back. This will be a pink, brighter burn, a different color, but the skin is there. So it's really important for us to do education with families, especially the darker your skin, the more striking the difference is. The melanin actually starts coming back around the hair follicles. It comes back in like almost polka dots where the hair base is, and it spreads out and it starts lighter and then it gets darker over time. And if the patient is not going to scar, it will eventually normalize, but it can take months. Once we have a healed burn like the one we saw there, it's really important to do scar massage. This helps normalize the sensation. We can touch the area. The patients have had a bandage for somewhere between 5 days and multiple weeks. It's hypersensitive area. It also, if we put pressure on it, can help prevent a thick raised or hypertrophic scar. We go in different directions. Moisturizing helps with itching. Burn scars can be very itchy. They can be quite dry. Any gentle moisturizer, Aquaphor, cocoa butter, Aveeno, Eucerin. There's many different options, but we really highlight moisturizing and scar massage. The other thing that's really important, especially because you don't have that melanin and the skin is fresh, is to protect the burns from the sun. That doesn't mean don't take them out. We have patients whose families will say, oh, we just won't take them outside. No, that's not fair. This is going to be a month's process. We just want it protected from the sun. Best tolerated is a broad spectrum mineral-based sunscreen instead of a chemical sunscreen. So this is more of a barrier sunscreen of at least an SPF of 30, and then half for the face, sun shirts if you're UPF shirts if you're going to be in the water, because otherwise sunscreen just washes right off. Our PT and OT team is, in addition to function, is very involved in our hypertrophic scars. So they have a couple different tools to evaluate the depth, thickness, and color of a burn scar. So if you're going to scar, if you have a deep partial or full thickness burn injury, it's going to be thick. It could be purple. It could be itchy. It could be pink. It could be a 0.5 millimeter. It could be yielding to pressure. It could be 3 millimeters thick. There's lots of different depths of, and this is also very heterogeneous in terms of the scar you can have. We generally can predict which types of burns are going to have a scar, and in those cases, we try and make it the best scar we can. So in addition to doing scar measurements, we will measure patients for compression garments that are fit exactly to their body. This is a doll I have in my office. If anybody wants to see her in real life instead of this horrible picture of her, this is her compression garment. So they can make them for the face. You can do a chin strap. You can do a hand. We do gloves. We do vests. We do shirts. We do all sorts of things to put compression onto the area to help prevent a thick, hypertrophic raised scar from forming. Silicone can soften a hypertrophic scar. And then if you get to a point where you have such a severe scar that it is either cosmetic or symptomatic, or we're having issues with range of motion, we do steroids, laser therapy, and sometimes scar excisions and revisions. This is the contact information for our burn team. We're available with nurse practitioners on the weekdays, and our phone number is here. You can find us in the Zebra phone under trauma burn. You can also email us, and then the general surgery residents cover our burn team as well. And this is just to say that it can happen to anybody. I'm a burn nurse practitioner, and I have been doing this for a long time, and I was in the ICU before this, and this is my third child standing in the oven. Yes. My first two never attempted to stand in the oven. And if you look closely, I mean, the dog's not helping, but I do have these things that go into the oven that kind of protect from the knobs, and so that they can't pull things down while she opens the oven. Obviously, the oven's not on in this picture. I wouldn't stop to take a picture if that were the case, but the little plastic guard is on the floor and the lock was not on. So it happens quick, and it happens to anybody. All right. Any questions? That's great. You're welcome.